COVID-19 is classically associated with lung disease and hypoxia. However, multiple neurologic sequelae have been described. Lance-Adams syndrome, also known as chronic post-hypoxic myoclonus, is a rare consequence of hypoxic brain injury. It is a clinical diagnosis that includes dysarthria, ataxia, and action myoclonus. Our case is a 34-year-old Hispanic male with no significant past medical history except a positive SARS-CoV-2 PCR test 10 days earlier. He presented to an outside emergency department following a witnessed respiratory arrest at home. The patient reportedly had a finger pulse ox reading of 10% when the emergency medical services arrived. A reading this low is likely erroneous, as devices are inaccurate below a reading of about 80%. However, it is likely the patient had significant hypoxia for several minutes. A laryngeal mask airway, or LMA, was placed in the field. Vital signs on hospital arrival are listed in the left panel. Notably, he had a Glasgow Coma Scale score of 3, was afebrile, tachycardic, tachypnic, hypertensive, and hypoxic. In the left panel is a diagram illustrating the patient's oxygen saturation throughout the emergency department. Initially, pulse ox with LMA in place was 87%. Just prior to rapid sequence intubation, saturation had dropped to 80%. Immediately following intubation, pulse ox dropped again to 75%, despite an FiO2 of 100% on the ventilator. The patient was administered rocuronium, PEEP was increased from 14 to 20, and pulse ox subsequently rose to 94%. The initial arterial blood gas was consistent with an acute primary respiratory acidosis with a secondary metabolic acidosis. He was transferred to our facility to be evaluated for extracorporeal membrane oxygenation, or ECMO therapy. In the center panel, initial lab work is listed from both the outside hospital facility, which is in parentheses, as well as the first set of labs at our hospital facility about 9 hours later. Multiple markers of inflammation were significantly elevated, including D-dimer, procalcitonin, LDH, and ferritin. He had a significant lactic acidosis, which resolved after fluid resuscitation. He also had a critically low serum sodium of 111 millimoles per liter. The line graph in the center panel illustrates the patient's abrupt change in serum sodium over the initial 24 hours. The patient's hyponatremia was thought to be acute. However, out of an abundance of caution and to avoid rapid overcorrection, the patient was given intravenous D5W and desmopressin. In the center panel on the bottom is a timeline of the patient's course. He was intubated on hospital day 0 and extubated on day 6. On day 8, the patient was alert and oriented, but was found slumped over in bed, making few spontaneous movements. The following day, he exhibited rigidity, myoclonic jerking with both active and passive motion of his extremities, dysarthria, and dysphagia. An MRI of the brain was obtained and is shown in the center panel. It was significant for cytotoxic edema in the bilateral cortices and basal ganglia. Importantly, the pons and major vascular flow structures were intact. Neurology was consulted due to high suspicion for Lance-Adams syndrome. The right panel includes a description of Lance-Adams syndrome. Important features include onset being days to weeks after the hypoxic event, a normal state of consciousness, myoclonic jerking of distal limbs and facial muscles with active or passive movement, and cerebellar dysfunction, all of which our patient displayed. The pathology is thought to be due to reversible ischemic damage. Despite significant motor impairment initially, symptoms usually improve with medications, time, and aggressive rehabilitation. Below is a table listing the most important differential diagnoses we considered. There was low suspicion for osmotic demyelination, considering normal appearance of pons on MRI and the acute nature of the patient's hyponatremia. Electroencephalogram did not show seizure activity. CSF, serum, and urine studies showed no evidence of infection. Metabolic etiologies such as toxic metabolites and electrolyte disturbances were ruled out, and no medications were thought to be contributory. Our patient responded well to valproate and was provided with aggressive physical, occupational, and speech therapy. A feeding tube was placed due to dysphagia. If we return to the timeline in the center panel, on hospital day 72, the patient was discharged. 3 months later, he was seen via virtual visit and exhibited only mild jerks in his extremities. He had transitioned from a walker to a cane and demonstrated full recovery of speech and swallowing. He was seen in the clinic 1 month later and was walking and jogging without any assistive devices. 3 months later, he had complete resolution of myoclonic jerks and tremors. Persistent impairments include difficulty with short-term memory and frequent nightmares and flashbacks of being ill. He continues to work with internal medicine, neurology, and psychiatry.